Hello. Thank you everyone for joining and welcome to yet another live Q&A event from Tinnitus Quest. We were a little bit nervous just now, had some tech issues to resolve at the last moment. I think we resolved them. You never fully know with these live events. If any issues occur, I apologize in advance. So we had a Q&A 2 weeks ago where we celebrated our first research grant, and that Q&A was with members of our executive board, including myself. Today, we're covering the same topic, but with two of the researchers who are involved in the project, and I'll introduce them in a moment. During that Q&A 2 weeks ago, I also gave a brief presentation at the beginning on Tinnitus Quest and what we've achieved so far in our first year and a half of existence, so I won't repeat any of that. But if you're interested, you can go back and watch the recording of that event. Just go to our website under events and then past events, and you can watch any of our previous Q&As there. I will, however, give a brief recap of the project itself. So the project that we're funding with our first research grant, just to kind of refresh your memories, or maybe you're even hearing it for the first time. So briefly do that in a minute or two, and then I'll introduce our speakers as well. So the project that Tinnitus Quest is funding with our first research grant will evaluate whether non-invasive transcranial ultrasound stimulation, or TUS, can suppress tinnitus symptoms by targeting deep brain structures that are thought to be involved in generating tinnitus, and also to find the optimal deep brain targets and TUS parameters for the reduction of tinnitus loudness. The study will focus on three targets: the nucleus accumbens, the caudate nucleus, and the medial geniculate body. These areas were selected because previous deep brain stimulation studies, so that's studies where they actually go direct physically into your brain, so it's a surgery essentially. So through these studies, targeting these same structures has shown promising reductions in tinnitus symptoms. So with TUS, we may be able to reach these same areas, but in a non-invasive way, so not requiring any surgery, but potentially giving the same benefits. And this hasn't been tried before for tinnitus, so we're very excited about this project. To introduce our speakers for the day, so Robin Cleveland is here. He is the principal investigator of the study, so that means he'll be leading the study. He's the director of the Institute of Biomedical Engineering at Oxford University and also a professor of engineering science. He received his PhD in mechanical engineering from the University of Texas in Austin and has studied the effects of TUS on Parkinson's disease previously, and I believe also pain. Then we have Will Sedley, who is a consultant neurologist at Newcastle University, who has had a research interest in tinnitus since 2008. He leads a research group running studies with human volunteers with and without tinnitus, with the aim of better understanding the brain mechanisms of tinnitus and developing innovative ways to treat it. I also have a co-host with me today. That's Bill Fennelly. He's here for the first time, so welcome, Bill. He's an award-winning stage director whose work has been seen on Broadway, off-Broadway, regionally and internationally, in theater and on television. He suffers from tinnitus himself, just like me and basically everyone who founded Tinnitus Quest. And he's been a supporter of our work since very early on, I think since soon after we started in 2024. And I asked him to be my co-host for this live Q&A so that you're not always just looking at my face and we can liven things up a bit. I will hand over to Bill in a moment because I had asked him start off this or kick off this Q&A with him doing like a mini interview with Will and Robin before we go to the audience questions. I'm sure there'll be lots of audience questions about the project itself, how the technology works, whether you can join the study and all of that. But I think it's nice to also kind of set the stage first and learn a little bit more about Will and Robin, who they are, their research interests, and things like that. So I'll hand over to Bill in a moment for that. In the meantime, you can start submitting your questions. You should do that in the box marked Q&A. There's also a chat box. I see people are actively chatting there. That's more for just like talking to each other and giving general comments. But if you want Will or Robin to answer your question, you have to leave it in the Q&A box. And I see some of you have done that already. Also, please, if you can and want to donate to Tinnitus Quest so that we can give out more research grants in future, just go to our website, tinnitusquest.com, and there's a button somewhere at the top. 100% of donations go into our research fund for future research grants. We cover our other costs through other sources of funding. So you'll be directly contributing to us being able to give out more research grants in future. Okay, on that note, I'm handing over to Bill, and go ahead, Bill.
Thank you so much, Hazel. We never tire of seeing you. So on behalf of everyone here, Hazel and Marku and everyone at Tinnitus Quest, thank you so much for all that you are doing for all of us. We cannot tell you how much we appreciate it. So I just want to start with gratitude and thanks to everyone at Tinnitus Quest. And Will and Robin, hi. Nice to meet you.
Hi, Bill.
Hi.
Great to see you. And Robin, your screen is frozen, but we can hear you just fine. And so we'll just chat if that works for everyone. Great. I'll kick this off. The two of you do come from different disciplines. What originally pulled you into your particular field of interest? I'll hand it over to Robin first, and then
Yep.
Will.
So my background actually is to do with acoustics, and in fact, my first work, I come originally from New Zealand. I did work in using ultrasound to find fish in the ocean, and then I did when I did my PhD in the University of Texas, I was at looking at sonic boom propagation from supersonic aircraft, sort of a daughter or son of Concorde-like aircraft. And then after that, when I started my postdoc, I worked with a group at the University of Washington in Seattle who did a lot of work in therapeutic ultrasound. So ultrasound obviously has been used widely to image inside the body, and that so as a diagnostic tool, it has decades and decades worth of experience. But the idea of using it to fix things inside of the body is something that's a little bit newer. So at that time, we were looking at how shockwaves can be used to break up kidney stones. So that was the translation actually of all the work I'd done with sonic booms. I could translate it across to using for shockwaves for breaking up kidney stones. I've since looked at using ultrasound for other applications, and that includes looking at trying to deal with disc pain. So using ultrasound to help fix with the lower back, using ultrasound to ablate and destroy cancer tumors, using it to help deliver drugs. And then probably starting about 6 or 7 years ago, we started looking at how we could use ultrasound as a tool for neuromodulation. And the first study was actually done in healthy volunteers. I was one of the healthy volunteers that was in that study, where we showed that we could modulate the visual system in our subjects. And then, as Hazel mentioned in the introduction, we've recently been funded by Rose Trees, which is a charity in the UK, and also by EPSRC, which is the main engineering research council that funds research in the UK, to look at Parkinson's patients and also patients suffering from pain. And we've got some really great initial data showing that we are able to modulate brain function in these patients. And that was sort of the motivation then to using this to try and widen tinnitus. So Will, do you want to talk about your background and how you got here too?
It sounds like a good point to do that. Hi. I'm learning a lot here already. I grew up in Cambridge, and although I've never been affiliated with the university there, went to medical school in Nottingham, and kind of just, I've always thought the brain was interesting, and particularly why we experience what we experience, see what we see, hear what we hear, and like the idea of exploring new questions. And was lucky enough to get one of a number of clinical research posts in Newcastle University, where they let you basically just develop and pursue your own research interests alongside training and posts in clinical medicine. And so I joined a group of Tim Griffiths, who was very interested in sound processing mechanisms in the brain, as sort of everything on offer that sounded the most interesting, and completely fell into tinnitus by accident. Tim suggested it. He said, you should do something a bit more clinically relevant. Why not tinnitus? And I have to be honest, my first thought was, it doesn't sound very interesting. Why not? I can't think of anything better. And realized quickly I was wrong. It's fascinating. It's important. And you don't need me to tell you that. And here I am all this time later. I thought I'll do this until it's solved, or I figure out it's not for me. And you loved working in this field. It's always a shame to not have more solutions yet. So I've just been trying to build a research base and group in tinnitus research in Newcastle ever since. And then I suppose how this all came about. My sort of mentor, Tim Griffiths, his other hat is he's a cognitive neurologist. So I did a fair bit of cognitive neurology work with him, and he runs a course. And his longtime colleague and collaborator is another neurologist called Chris Butler, who I know very well for years through that. And on one of these courses, so turns out Chris said to me, "Hey, I'm doing some ultrasound work with my colleague Robin. Wouldn't it be a cool idea to try this in tinnitus?" And the conversations that followed, at least to my understanding, are what's led to all of this.
That's great. That's great. We always love to hear a good "how did you meet" story. And my next question is, from your individual perspectives, where do engineers and neuroscientists often misunderstand each other's work, and where do you actually align better than we may have thought?
So I think from my perspective, I don't think we really misunderstand each other's work very well. I think sometimes our languages are a bit different. So the terminology we use, and so it's learning how to do that. And that's something that has been a real learning curve for me, is learning different parts of the brain, what parts of the brain connect to which parts. And so understanding the brain as a network has been something that I've had to learn along the path. But my experience that I've had over the past 5 or 6 years working with neurologists and neurosurgeons is that we actually are able to connect very well, and the ability to talk with each other. And so, as Will said, right, we've only connected over the last few months, but we've been able to almost immediately, the moment we started talking, we were able to talk to each other and find solutions. So we actually talk a very similar language, and we see problems. I think we actually see problems from a very similar point of view. So there's been no real challenges in kind of developing the proposals that we thought we would need for Tinnitus Quest to be able to fund it and to be able to address the problems. And so it's actually been a lot simpler than I thought it was going to be. I don't know, Will, if you want to double say me and say, no, you've got no idea.
So I would completely agree. I would go so far as to venture that all the instances I can think of where people from an engineering background have come into neuroscience or collaborated have been positive. I'd go so far as to say we need as many people with engineering skills and related skills and knowledge to get interested in clinical neuroscience, as many as possible. From my point of view, purely a good thing.
That's really encouraging. It's great to hear that. So I guess building off of that question, is there a concept or idea from the other's discipline that you have found unexpectedly useful in your own work or collaboration?
So I think for me, what I've found most useful, as I said, is understanding the brain really as a network with all these different connections that were going on. And I think as an engineer, for many of the problems we look at, we often do see problems as these connections where if you activate or control one part, you'll see responses elsewhere in the system. And so getting to realize that actually the brain has a lot of that component as well was one of the things that really I learned out of this. And what's not always clear is that for typically in engineers, when we connect things, we put things next to each other. And obviously in the brain, the way that the brain has evolved to make all those connections is quite different from how we might lay it out as an engineer. So understanding that there is this map, but knowing that I need to speak to a neurologist who actually understands how the paths connect, and bits that are right next door to each other sometimes don't connect. And being able to understand that path has been really useful. Now,
Okay, I might follow on with that. Sorry, I had to nip out for just a second. My family are determined to do disruptive things like let the dog into the room. I think it's early days. So I think for me, the full things we'll learn from working together are yet to come, other than I would completely agree, rapidly discovering we have a lot of common purpose. I mean, it's really nice just seeing the approach to a fresh scientific question of someone from a different group or different discipline. But it's probably something I could come back to you with a better, more detailed, more experience-based answer later.
Well, we look forward to chatting more. And so when you hear the phrase neuromodulation, which we're hearing a lot these days, what does that mean in practical terms for your respective viewpoints or anticipated or hoped for outcomes?
Will, do you want to start on that one? You're a neurologist here.
Yeah. I might start with the broadest term possible, because to me, neuromodulation is anything that you do or are presented with or are subject to that changes the function of your nervous system, which means literally absolutely everything that comes in, either through your sense organs, any of them, or as electrical magnetic impulses to the brain in any other way. So I think, in one sense, anything we're trying to do to help tinnitus comes under neuromodulation to some extent. But I guess, if we're getting a bit more reasonable and less pedantic about it, we would probably say, well, medications we might call something else. So I suppose for me it's things that are trying to change or aiming to change patterns of ongoing activity in brain centers or networks related to the symptom or condition in question, tinnitus. But actually, this can be really broad. I think in reality, people mostly have meant something involving, I think in most cases, people have meant something involving either electrical or magnetic stimulation, but ultrasound very much joins those ranks. And then many forms involve another modality. So you'll hear terms like bimodal stimulation a lot, which can mean that usually means sound is one of those. And it makes sense. You'd pair sound with something else to change the way our brain processes sound. That in itself can take kind of one of two approaches. You can do things at the same time and hope they have some synergistic effect. Or you can precisely time them rather than doing them just around about the same time period, because you think they interact in a very specific way. And then you can do neuromodulation with sound alone. But sound is a very powerful window into the brain also. And if done in the right way, and there have been attempts at this. So for me, it sits somewhere, ultrasound very much sits within this sphere.
Mm-hmm. Yeah, and I think from my perspective, again, historically, the brain has very much been seen as an electrical network where electrical signals pass through. And so the idea with deep brain stimulation, for example, is that there is a misfiring in some of the electrical signals passing in the brain. So by putting an electrode into a specific spot and sending electrical impulses, you can then hopefully correct a misfiring that's occurring. And so, for example, the Parkinson's patients that I have been working with, they have all had deep brain stimulation to help control the tremor that they suffer from. But it turns out that the electrical signals that pass through your brain, they do have electrical components, but there's actually also a mechanical component. These action potentials, when they go down an axon, there are ions that move in and out, but actually the membrane of the axon deforms as the action potential goes down. And so there's a mechanical wave associated with the action potential. And so the reason actually I started working on neuromodulation to begin with was because I actually didn't believe the first results that were coming out probably about 8 or 9 years ago. It seemed very unlikely that ultrasound would modulate brain function. It's an electrical signal. Why should a mechanical wave do this? And so it actually turns out because there are mechanical components to our axons, the ultrasound energy can couple in and actually affect how action potentials go along a neuron. So that was I started doing this thinking I was going to be the grumpy old troll that shut down ultrasound neuromodulation because there's no way it could happen. But it turns out that it does actually have a modulation effect. And what's particularly comforting is that the energy levels we put in are no more than you would do for a diagnostic ultrasound scan. And so we have a really good understanding of the safety envelope associated with delivering ultrasound energy into the brain in these regimes. And so it's been a really nice mix of one being completely surprised by the fact that there's a mechanical component to the signals that pass in your brain. And the two is that for the levels of ultrasound that we need for diagnosing imaging, that seems to be enough to be able to modulate and change how the brain functions.
That's terrific. That's terrific. And it's exciting to hear that your questioning led to discovery and further research.
Yeah.
I know it's early days, but if you had to look forward, what might success look like in 3 to 5 years from now?
So for me, success would be having a system that people could use to be able to quieten their tinnitus. So something a little bit like the headphones that you're wearing right now, where it would perhaps go just over the temporal windows on the side of your head, where the ultrasound could be delivered. From the point of view of success, my hope would be it would be ultrasound that might be delivered, say, once a month, where you go in and have some ultrasound that would help quieten. Right now, most of the data out there where people have been able to give modulation in the brain, and that includes some of the decision processes, some of the processes associated with pain. It lasts for about somewhere between a day and a week, depending which study you believe. So you do have this long-term effect that can go over that period. And so what I would hope over the 3 to 5 years, we could find a delivery protocol that would work to quieten tinnitus for some multiplication factor of that. And it could be 2, 3, 4 weeks. So that I think is perhaps a realistic goal. Obviously, an ideal goal would be something where you'd have ultrasound treatment maybe once a week for a month, and then that would actually quieten your tinnitus ideally for years, right? I mean, if I was going for something that I would really love to see, that's what I would hope to see. But I think so. Those are kind of two visions that I can see going forward as to how ultrasound could be used and might be in a sort of shape in 3 to 5 years. But the nice thing about ultrasound is, we have decades worth of experience of people developing ultrasound transducers and being able to deliver ultrasound into the body. As I said, both diagnostically, but now also therapeutically. And the costs associated with making an ultrasound system are quite low in comparison to many other medical technologies. So we have a big advantage from that point of view. They're small, they're portable, they're relatively low power, they're relatively low cost. And so, I mean, the vision that Will and I have had when we were putting this together is that this is actually something that could be used very broadly, not just across the UK, Europe, the US, but across the world as a whole, because both the costs and the power requirements associated with ultrasound are so low that actually being able to deploy it even remotely is quite plausible and at a reasonable cost. Yeah. Will, how do you see things in a few years from now?
Yeah, I think that puts things really well, and I'd very much trust Robin's expertise way over mine on cost, availability, portability, treatments that you can do at home versus ones that you go into a clinic. I mean, I think starting starting at the beginning, approaching the question from the other angle, we would first want to show that the ultrasound quietens tinnitus while you're giving it, and then in the immediate period that follows, and then looking at how long effects last. Do repeated courses give cumulative effects? And there's a whole huge number of parameters, but essentially these first 3 rounds, making the effect as strong as possible and as long lasting as possible. What are the best protocols? What are the best targets? Is one target the best? Are multiple? But I think it's really difficult to know where the long term lies. I mean, what everybody would like is to A, silence tinnitus, and B, make it not come back. And we think that tinnitus persists because of something that many listeners here will be familiar with, called neural plasticity, which broadly refers to the brain's ability to make or modify connections and learn to remember and to recognize things. And unfortunately, our brains are so good at that. Once they recognize tinnitus, the tinnitus signal, they almost can't help but not do it, whether you want the brain to or not. So there may be other parts of the puzzle. We really don't know. Say this got so good, we could disrupt the network enough or enough bits that the tinnitus went away. Is simply quietening tinnitus enough that it won't come back? Can you quiet it for long enough that it doesn't come back? Or do you have to do something else that enhances neural plasticity so that once it's gone, then you do something that helps the connections in the brain kind of reset themselves to the current state? So, I don't think it's implausible that in the long term, this is part of a real lasting solution. But as Robin said, I think a next best is something with an enduring effect where we can find logistically how it can be incorporated into people's lives widely and cheaply to give them lasting relief. So let's see. Time will tell.
Mm-hmm. Yeah, thank you both so much for your clarity, your insights, your specificity, and your care. We really appreciate it. Thank you so much. It was great to meet both of you.
Thank you so much for preparing this little mini interview, and I think it's a great way to set the stage and get to know Robin and Will. And we will now move to the audience questions. And there have been quite a few that have been submitted, and Marco, who's working behind the scenes to manage all the technical aspects, has been monitoring them, and we'll start pulling up some questions in a moment. And of course, we're all aware that, Robin's video is frozen, and sorry for that. Sometimes things go wrong with live events. What can you do? We promise to give you more visuals of him in future, but at least we can hear him. And so I will ask Marco, yes, to pull up the first question. All right. How is the depth and location of tasks targeted? How many different brain regions will this study stimulate? Yeah, I think we'll start with Robin on this one.
Sure. Yeah. And so the way we target right now, and the way we'll do this for this initial study, is the subjects that take part in this trial will have an MRI scan done, and that allows us actually to then get a complete 3D map of the brain. And then the 3 targets that we're going to be targeting are the nucleus accumbens, caudate nucleus, and the medial geniculate body. We will also target the lateral ventricles. That will be our control site. So the lateral ventricles are the parts in the brain that have CSF. There's no brain tissue in there. And so when we apply ultrasound to that area, we would not expect to see a neuromodulation effect because it's essentially water, the CSF. And so those are the 4 targets that we will be going. Every subject who takes part in that will have each of those 4 targets being insonified. So it's not like if you go up to this trial, you might be one that doesn't get ultrasound applied to a part of your brain that might quieten your tinnitus. So everybody who takes a trial in this will have a control site treated, as well as having the 3 potential active sites treated with ultrasound. Yeah, Will, is there anything you think I missed on that?
No. I mean, I think you've, in terms of where we're targeting, it's those areas, probably both sides of there's 2 of each of these areas, 1 on each half, and I think we're targeting both and see where we get to. And I think if this works well, run with this. If it's not enough, there's scope to try and do multiple areas, but the more technical requirements you add in, the harder it is to sort of scale up. So I think we know what the starting point is, and there are various ways it can be revised and tweaked if there isn't the initial success that we think there hopefully will be.
Yeah. On that note, Will, can you maybe explain to the audience the 2 phases of the study, and like how in phase 1, you aim to sort of refine the targeting, and then what will happen in phase 2?
Yeah, thanks, Hazel. Yeah, and indeed. So phase 1, the question is, can we suppress tinnitus at all? And we'll use several measures of tinnitus, which include actually something it's very hard to beat. How loud is your tinnitus on a scale of 1 to 10? And do this sort of throughout and in the time period that follows, along with minimum masking levels, psychoacoustic loudness. So some nice measures. Track it during the stimulation block, which you can do because the ultrasound doesn't have energy at the tinnitus frequencies. It won't necessarily mask it. What happens immediately afterwards, and then what happens in the days that follow. So phase 1. What does 1 session do? Can we clearly reduce tinnitus at all against a non-active site? So taking care of any placebo effects. And then if we've got some success criteria, how much we want to be able to suppress tinnitus for how long, that it seems worth proceeding to phase 2, which is if you come for a course of sessions where you repeatedly each time target the same brain region, then can you get a cumulative and more long-lasting effect? What's the biggest total effect? How long can you make it last? So I guess phase 1 is suppression for immediate through seconds, minutes, hours, days. Phase 2 is sort of days, weeks, months in mind. Those are our target areas. Have I put that fairly, Robin?
Yep, that's right on. Yep.
All right. Then, yes, next question. Okay. From Zach, is the decision to avoid targets like the auditory cortex or dorsal cochlear nucleus driven mainly by technical constraints of ultrasound stimulation, or do you hypothesize that your chosen brain sites are more important in the context of tinnitus?
So from my perspective, it's the latter. We did some good amount of searching through the literature, and the sites that we've chosen are ones that people have trialed with deep brain stimulation, where electrodes have been invasively implanted into the brain and have shown that these areas result by stimulating them. You get quietening of tinnitus if you electrically stimulate them. And then because of the data that I've done with Parkinson's patients, where we see that ultrasound mimics what DBS does in Parkinson's patients, we have used this as a motivation as to if there are sites that seem to work for quietening tinnitus with DBS, we feel very confident that ultrasound should also be able to quieten tinnitus in the same way DBS does. So that's been the motivation for doing this. I think if we get good results, I think looking at other targets is something that would be a good follow-on after this. But there are probably a huge number of sites that somebody could argue may be able to control for tinnitus, right? And we can't look at all the sites at once at the same time. So we kind of picked what we think were the 3 strongest candidates. Hopefully we'll get some really good results from that. But it may be as we continue on down this path, we find that there are other sites that might be worthwhile looking at and investigating. But there's no ultrasound reason as to why we can't. I think from an ultrasound point of view, I can get to both the DCN and to the auditory cortex as well as if I needed to. So the focus really has been on prior data.
Right. But I think it's important for the audience to understand, and you guys should correct me if I'm wrong, but with other stimulation technologies, you could not reach those deeper brain targets, right?
For non-invasive, yes. So you can reach them with DBS, right? They can put electrode pretty much anywhere in the brain, but then you have to have a hole drilled in your skull and an electrode inserted all the way through the brain tissue. So where the advantage with ultrasound is we can go to deep targets and we can focus, but we can do it non-invasively. We don't need to make an incision in the body. We just put a transducer up against the side of your head. Yeah.
Exactly. Yeah. Will, do you have anything to add?
Yeah, no, thank you. No, I mean, I would agree with all of that. And it's a great point you raise, Hazel, because there's been a lot of non-invasive stimulation work that many of you will have seen in tinnitus, particularly using forms of transcranial magnetic or transcranial electrical stimulation. And these are both, they're very broad. They're not focused to any high degree. It's completely different to ultrasound, but also they are limited in their depth, as we've just said. So a lot of the brain is off limits. So Robert has absolutely put it well. I mean, taking a step back, there are theoretical grounds to target half of the brain by the time you've added all the areas that at some point have been implicated in tinnitus with some evidence or some theory. And there's been a really clear, sensible decision to go, let's put theory aside because so many theories are inconsistent, or so much of the tinnitus neuroscience evidence is not replicated or is not totally proven or consistent. Let's go with what actually works when you stimulate it. But I think that there's a very clear appetite. If these areas don't work or don't do enough, we'd go through every area in order of how strong the case is for targeting them, which include any areas in the auditory pathway. I've seen things coming in the comments. Auditory cortex, you absolutely can hit. We talked about this with Dirk de Ridder, who probably of anyone in the world has done the most, possibly only implanted auditory cortex stimulators for tinnitus. Even he said, yeah, look, you could do it. I think you're right not picking it as your top target, because of the handful of people he's implanted, there has been 1 or 2 cases of resounding success for tonal tinnitus, where you can find the exact spot on the auditory cortex that represents that frequency of tone. But then there were many others with that invasive surgery who didn't benefit. It won't work for non-tonal. So it's there. It can maybe form part of a solution, but we haven't started with it. And because it's an area that can be reached with electrical and magnetic easily, we kind of know what stimulating that does. There are other areas, deep areas, that'd be very exciting to target if ones currently tried don't work out. Hippocampus and parahippocampal cortex are ones including, as well as those mentioned, dorsal cochlear nucleus, inferior colliculus. So the list is really long, deep areas in the anterior cingulate cortex relating to sensory gating. I think it's wonderfully exciting, actually, that there's a whole set of possibilities. This is sort of green fields or blue skies, whatever we talk, and we're just starting with those that already have the best evidence for targeting them. I saw another question coming in. Sorry, I'll be quiet in a minute, saying, if you do find it works, could you ablate the area? In principle, you could. In principle, you could deep brain stimulate it. So another offshoot that we've talked about, we're getting ahead of ourselves. If this works, but the effects are just not always as durable as you like, this would mirror other areas of medicine, pain, and other conditions where, for some, non-invasive neuromodulation may last weeks and months. And sometimes it never returns to the same severity after one course. And then in other times you get a really good response, but it's short-lived and you move to something more invasive. So I think it's, if this goes well, this is bringing tinnitus neuromodulation into the same kind of, part of the mainstream as neuromodulation, invasive and non-invasive, is in some other areas of medicine that are further ahead.
Wonderful. Yeah. Thank you, Will. Okay, we'll move on to the next question. In your previous studies, participants could hear the ultrasound and a masking sound was used to control for this. How do you intend to control for this undesirable perception? Well, I'll let you comment on whether it's undesirable. From what I heard, it's not that loud or anything, but while still allowing the participants to hear changes in their tinnitus in real time. Okay, there's a lot of aspects to this question. Who wants to kick it off?
I can start. So one, it's undesirable, not from the point of view it's disturbing. I mean, the sound that you hear, and you actually don't hear the ultrasound, just to make that clear, because by definition it is ultrasound. We use frequencies of 500 kilohertz, right? And upper hearing of acoustics is normally determined at 20 kilohertz. So we are, a long way above what we can hear. So you can't actually hear the ultrasound. But to get the neuromodulation, what we do is we pulse the ultrasound on and off. And it's actually, you can hear the pulsing. So the bone absorbs a little bit of the ultrasound. It sends a little flexural wave that goes around the skull, gets to the cochlea, and then couples into the auditory pathway that way. So, and as the questionnaire suggested, we mask that. So while the ultrasound is on, we apply a masking sound so that the participant can't hear. So it's undesirable from our point of view because we don't want our participants to know when we do basic science whether the ultrasound is on or off, because we are doing controls on and off. So it's undesirable from a scientific point of view because it's a cue that your participants can use to determine whether the ultrasound's on. So that's why we mask it, so that they have no idea. So what we will do is we will use a masking sound when the ultrasound is on, and also when we're doing control pulses where there's no ultrasound at all. But then we will turn the masking sound off for them to give us a measure of their tinnitus. So while they're doing the assessment of the tinnitus loudness, that will be done when there's no masking sound present. Will, do you have anything to add on that?
The other further thing that makes me far more relaxed about this than I would have been is the acoustic artifact that you get from the ultrasound, and therefore what masker you need is all in the lower frequency ranges.
Yeah.
I don't think any of this is going to involve sound energy above 2 kilohertz. So this won't even overlap with the same frequency territory as people's tinnitus. So there shouldn't be any direct masking effects. It might be marginally distracting, and occasionally there are cases where sound at a low frequency still slightly changes your experience of tinnitus at the high frequency. So this it may not affect tinnitus at all. It may affect it a bit. Even if it does, as you say, Robin, the main assessments are what happens afterwards, not during. So this is a minor factor for us to take care of. This is not going to threaten the tolerability or effectiveness of this.
Yeah. So just to clarify, Will, it's not necessary for participants to be able to monitor any changes in their tinnitus during the application of the ultrasound, right? Because you're not looking for those real-time immediate changes per se, or are you?
We will look for them, but we don't need them. It's icing on the cake.
Yeah.
Okay, gotcha. Yeah, so you're trying to establish a long-term effect or reduction of the tinnitus. Yeah. Okay, let's see what else we've got. From Morgan, would it be reasonable to expect us to work on all forms of tinnitus, whether it's TMJ, so jaw-related, noise-induced, Meniere's-related, anxiety, temporal tympany, I always forget the something syndrome, concussion, etc. Right? So there's many causes of tinnitus. This is a whole separate discussion. To what extent do subtypes of tinnitus matter? Are there meaningfully different subtypes of tinnitus that should also be treated differently or not? There's no real consensus on this in the field. We know that also from the tinnitus hackathon that we did back in October, and there was a split in the room on this exact topic. But yeah, what do you think, Will?
Thanks. My short answer is I don't see any reason why it should be applicable only to some of those subtypes. But we don't know until we test it. So short answer, I think it has just as good a chance for working for any of these, and I don't see why it should definitely matter. To give some of those specific ones, I mean, in a sense, most cases of tinnitus, we think, however it comes about, they involve hyperactivity, too much firing rate of neurons, or too much synchrony between them, or something that is excessive in the auditory pathway and other bits of the brain that interfaces with. We're looking to modulate to turn that activity down. So however you got there, we think would be acting at something that is a common pathway. The TTTS, tonic tensor tympani syndrome, I guess if we're considering this, if you're constantly, well, I suppose I'm not an ENT surgeon and so risk exposing my ignorance here. But if you had something that is creating sound by activating the tensor tympani, causing sound in the eardrum, or cases of objective tinnitus, like hearing pulsatile tinnitus, where you're hearing blood flow and that kind of thing. It clearly, ultrasound would be unlikely to get to the source of that if you're stimulating the brain, but could you still modulate how sensitive the brain pathways are to picking up that sound? Potentially, yes. So we're looking for sort of typical subjective tinnitus cases, but I don't think we'll be bothered about etiology. I saw things popping up. Doesn't matter how much of a player, severe hearing loss, anxiety, head injuries. I don't think any of those are going to be inclusion-exclusion criteria for the trial. All of these end up just causing a form of subjective tinnitus. We know there's some hearing loss to some degree in most cases. So I don't think any of that's going to matter for the trial. And actually, in terms of the level of hearing loss, one nice thing about not requiring sound as any of the parts of this, at least in this form, there's no reason you couldn't use this even with total deafness. So unlike some techniques where you still have to have enough hearing to hear the sound input, here it shouldn't make any difference. So actually, we see this kind of being as open as it gets in terms of the range of cases of tinnitus it might be applicable to.
That's
Hazel and Will, just to jump in because I'm following along with the chat. Do you, in terms of subtypes, do you think that you will be cataloging or capturing the information of potential subtypes as you conduct the study?
Yes. Right. In short, yes. We will get all the information about etiology, hearing, tinnitus characteristics, behaviors. We're not going to be powered to make concrete distinctions between them, but we certainly want to capture that information and get a hint about it.
Is a great follow-up question, Bill. I was actually going to ask the same thing, because just collecting all that information just in case, so that if you later are able to make some connection between, why certain people respond better than others, etc., and what are the characteristics between those different groups, then of course you need to make sure you collect the data up front. So yeah, that's a really good point, Bill. I saw a next question already pop up. So yeah, from Narain. Hi, I'm wondering if the target of this new research is the severe cases or also the milder cases that still dream of regaining full silence. Also depends here what you mean with severe, etc. It's a tricky. Again, because we don't have fully objective measures of tinnitus, right? But yeah, go ahead.
Should I take this one, Robin?
Yeah, Will, you start off on this one, I hope.
Yeah, I mean, I think the short answer is the aim here would be to give the best chance of achieving quietening or silence of tinnitus to anybody who has a tinnitus sound and doesn't want it to be there. So we don't envisage restrictions per se on severity. For these initial trials, we're looking for a relatively broad range. I think we would be looking for a kind of tinnitus handicap inventory score indicating at least moderate tinnitus symptoms. But in the longer term, if this works, we wouldn't see any reason it should only work for such cases. It should work for milder ones. If there's then questions that we couldn't possibly answer now, like if this ends up available, funded by different countries, health services, etc., and different insurance companies, what would their criteria be? Who knows? But in terms of what it should work medically for, our aim would be this, again, just as it's non-discriminatory to subtypes if they exist, it should be non-discriminatory to severities.
Yeah, certainly from the ultrasound point of view, there's no reason for me to feel that if it works for moderate or severe cases, it should also work for mild tinnitus as well. Yeah.
Makes sense. All right, let's move on. From Nell, wouldn't targeting lower parts of the auditory pathway in the brainstem, inferior colliculus, DCN, imply particular risks because of their small size and promiscuity to maybe that means something else, but to vital function areas?
Will, do you want to take a lead on this one?
Yeah, I wondered if you would. I mean, this is more your area, but I suspect we're going to say the same thing. So one of which is, I think if you were going to target these areas surgically with something invasive and destructive, yes, you could do it if you could justify it, but risks are higher when you get into that delicate area. For ultrasound, and Robin, you know the safety data much better than me. The safety data are really well established. There's a very clear idea of limits that if you stick within, you just are not, you have no plausible chance of doing any damage to any tissue. So for me, I think this argument is precisely why ultrasound would have this advantage over invasive techniques.
Yeah, no. So I think, and you keep in mind, right? Well, we are not doing ablation here with the ultrasound, right? So we're not destroying any tissue. So the fact if there is neighboring tissue, right? The only issue when you get particularly small sites is whether we can focus the ultrasound down tightly enough to be able to perhaps impact that target and not also stimulate nearby areas. So again, our focus really has been on finding targets that seem to have the most promise for quietening tinnitus. But if some of these other targets, as we move on, also show a response to ultrasound, then essentially it becomes a money problem. If you give me enough money, I can probably target ultrasound to any point in the brain. And it's finding what tools you need. Now, some of these locations get a little bit trickier. If there's a lot of bone structures nearby, being able to target to tight points near that can become a challenge. So it becomes an engineering problem that we need to overcome. But there's sort of no real risk from the point of view of damaging any tissue because we are operating in a regime where we're not doing any damage. We are just giving a temporary modulation to some of the brain function.
All right. We'll just move on to the next question. From Elisa, might this approach be unhelpful for hyperacusis sufferers?
And I was keeping an eye on the chat. So I think this might have been about MRI, the fact that I said we were going to do MRI for.
Oh, that's possible.
And this is, right, so obviously being in an MRI coil is not a good environment in that case. So the reason we're doing MRI to begin with is so that we have a really good map of brain function. Our goal in the long term is actually to use things like brain atlases and other markers to be able to target locations without needing to do an MRI of every subject. But to begin with this first trial, we want to make sure that we're hitting the targets that we're going to hit and that we're as accurate as possible in hitting those. And then once we get positive effects and we know which targets are the most promising, then we can look at, well, rather than doing MRI, can we use a brain atlas to take features of an individual and actually predict how we can get there and then look at how much imaging we need. Our hope is that we will not, in the long run, we won't need to do MRI. Somebody also asked in the chat about whether AI might be useful. For what we're doing right now, AI is not very useful. We need to do these fundamental studies to understand the interaction. But where I think AI could be useful is taking information about individuals and being able to tell us how we can target without needing to do an MRI. I don't know, Will, are there any other issues that you think hyperacusis may be an issue about what we're doing?
Well, only to add that actually, we'll collect data on hyperacusis symptoms. I can't think why the ultrasound itself would make hyperacusis worse. And there was a question about could it make tinnitus worse? I think unlikely. And if it did, we'd pick it up in phase 1 in the short term and we'd take a steer. And we had discussions that actually if doing a particular thing to a brain region makes tinnitus worse, you can stimulate it in a different way that does the opposite to make it better. So we wouldn't even run to phase 2 for any long-lasting effects. If anything, we're making it worse. Deep brain stimulation so far has only made cases of tinnitus better, not worse. Coming back to hyperacusis, there's every reason in principle that inhibiting hyperactivity in the auditory pathway or doing other things in the brain's networks that reduce auditory hyperactivity might help hyperacusis as well. So although it's not the primary aim, it'd be really interesting to see what happens to hyperacusis symptoms along with tinnitus symptoms.
Yeah, absolutely.
That's great to hear. Hazel and Robin, I have a follow-up question.
Yeah, go ahead.
It's a new term for me, and it might be new for others as well. Robin, can you talk us through what a brain atlas is? What's involved?
Oh, yeah. Good point. I don't know that one either. Yeah.
Yep.
Neither.
So, the everybody's brain is different, right? We're all unique, but there's a lot of similarity. And so, what a brain atlas does is it's a way of transforming an individual brain to a basic map that anybody can be aligned to. So, the idea with the brain atlas is if you can take some key features of a point inside the brain. If you know a few key features, you can then use that to predict where somewhere else might the target you're interested in, where that is going to be relative to those key features. So it's a little bit, I don't know, actually, Will, you might know this better than I do. You know brain mapping perhaps a little better than I do. Is that?
Yeah, no, I think so. And I think what we'd always talked about wanting to move towards and what you mentioned is if you can work out enough about what the structure of someone's brain looks like just from the outside of their head and knowing what lots and lots of other people's brains look like, then you've got enough information to target ultrasound, for instance. So it would be a little bit like saying, if we wanted to reach a particular area in your brain, but you didn't want an MRI, could we use the information from, say, scanning my brain and then looking at the external shapes of our heads, slightly deforming your head and tell it, my head, and tell it fitted the shape of yours, and then, using that to create a virtual MRI. It's that sort of thing. You have a standard template, and then it can just be, with a little bit of warping, it can be as good as actually having the image of somebody's brain without needing to get it.
Wow, that's amazing.
It is, yeah. I've also heard people speculate that one of the reasons some of the other brain stimulation studies in the past haven't worked very well is because they just kind of assumed the same map for everyone, if you know what I mean. They haven't sort of individualized it.
Mm-hmm.
Yeah.
I think there can be a lot of reasons that, and there's how broad they are, and then actually, I mean, particularly with electrical, we are using this, so I'm not throwing it out, but the majority of the energy doesn't make it all the way through the scalp and the skull. So a lot of it's going, A, isn't getting to the brain, but B, it's going to other places. It's going to all the rich nerve supply to your scalp that then feed into the brain and does neuromodulation in a whole different way. It has a similar effect to vagus nerve stimulation. So there's this whole thing of going, even where these other techniques have been working, are they working because of the way we think they're working?
Yeah.
Or are they stimulating the skin? And then that has a knock-on effect on the brain. So
the mechanism of action is something different than what we thought. Yeah. That's a good point. All right, let's move on. Yep. From Ray, there is a company called Nudge. Yes, we have talked about this. That is doing similar work. That recently got 100 million in funding. I should stipulate the 100 million is for lots of different conditions, not just for tinnitus. Unfortunately, that would be amazing. But is there any way to collaborate with them in the future? And we have been in touch with them, meaning Tinnitus Quest has reached out to them, and we're going to have a call with them. But I understand that, Robin, you had also already been in touch with them previously before you even applied.
That's right. Yeah. So yeah, I'm aware of the group at Nudge, and I know a couple of the people who work at Nudge very well, and that's a very good, strong company there. That then they have some really good, smart people working on that. They have indeed last year they raised $100 million for their effort. It is across. I mean, there are lots of different areas where they're hoping to apply ultrasound. It very much is a headset type system that would be mounted on the head with a sort of an array type device. So it's a bit different from what we're envisioning, and they are very much on the commercial line, and I think trying to make lots of money out of this. But there's still the fundamentals of understanding how ultrasound interact with the auditory system to be able to quieten tinnitus are still not understood. And these fundamental studies that, and again, both Will and I are so thankful for Tinnitus Quest for funding this, because you can't develop commercial systems until you understand the fundamentals of what's going on. And the study that Will and I propose is to really get a good understanding. But yeah, as Hazel said, we will have a call with Nudge. We will make sure we remain to collaborate with them. I think both Will and my goal is to whatever we can do to be able to get this technology out to as many people as possible at the most reasonable price is really our goal, is to make a contribution to changing how tinnitus is treated.
Yeah, 100%. Yeah, I think it's important that we connect with them to, at minimum, just make sure we're not like duplicating efforts, and that we're sort of complementing each other, right? I think that's the minimum, and we'll see if there's any further collaboration we can achieve with them. But you make such a good point, Robin, as well, with that Tinnitus Quest is trying to fund the type of research that otherwise would not get funded from commercial sources, right? And that's exactly, it's that sort of early stage discovery type work that we're wanting to fund, so that we can, if we do find something promising, that's probably when you can get commercial investment as well. But this is how it works with commercial investment. They're not going to invest until you sort of offer them something on a platter that is, not too high risk, let's say, and seems to have a reasonable chance of working.
And the other thing to keep in mind, right, is it also means that if there are people in the US who are willing to put serious money into this, they also believe that ultrasound has potential, right? This is a suggestion that there's a recognition across the world that ultrasound is a modality that has potential. And again, my experience with solving a lot of these medical problems, you need to have multiple teams looking at this, because everybody comes in with a slightly different perspective, and you can't put all your money on one horse in a race. And it's as true in race horsing as it is for basic science. You need to have different groups all looking at this, thinking. But again, the important thing, as Hazel said, is we need to make sure we communicate with each other so that we don't go down the alleyways that aren't going to be very productive. And as I said, I do know a number of the people at Nudge quite well, and we have good scientific interactions with them. And so I think if there are any things that either of us learn, I would be very happy to share, and I think they will be too, in being able to move this technology forward.
100%. Yeah. We're technically at the hour, but I'm gonna just suggest we do at least a few more questions, and I hope that's
Fine.
okay with you guys.
Yeah,
Perfect.
absolutely.
Yes, this is a really important one. We've discussed it also at length in the whole grant evaluation process, etc. But yeah, how will tinnitus loudness be measured?
Yeah, I'm happy for me to take this, Robin.
Yeah, please do.
Yeah, so three ways, and actually we're not reinventing the wheel. This isn't a study in what the best way of measuring tinnitus is. So we're taking the three best ways that already are widely used and doing all of them. We'll do a visual analog scale or numerical rating scale in real time throughout the whole thing, constantly, before, during, and after every block of stimulation for phase one. Along with minimum masking level and psychoacoustic loudness matching, where you tune a sound in the other ear, or both if it's both, until it's the same loudness as tinnitus. Phase two, it's the same measures. Obviously, people won't constantly measure their tinnitus for days and weeks at a time, but we might get them, for instance, to rate it every day. So how loud has it been that day? That's about it, really.
Yep. Okay. Well, I think we should just move on because we have plenty more questions. From Alan, what is the time frame for beginning the trials, and how will the participants be selected? Oh, and this question is sort of related. How many people will be part of the study?
So for the initial one, right, we're just starting to apply for ethics, right? So we can't apply for ethics until we have told we're going to get funding. So now we've had the clearance from Tinnitus Quest, we can get funding. We can apply for ethics to do that. That's typically kind of a 3 to 6 month time frame to get ethics, just depending on how much back and forth we get with the ethics panel on doing this. And then, but I'm hoping by the summer, we will be in a place where we can start to recruit and start the trial. In this initial phase, the goal is to have 15 participants for the phase 1 trial. And then, Will, do you want to talk perhaps about selection?
Yeah, and we've talked about this at length. We don't want it to be overly focused on a particular type or grade of tinnitus. So I think it needs to be relatively open in that regard. We just for an initial trial, basically, we decided there shouldn't be limits on tinnitus severity, but we want tinnitus to be the sole major ongoing medical or mental health problem for somebody. If there are other major ongoing health conditions at the time, we're not going to scientifically get a good view as to what the effects of just targeting the tinnitus are, even though obviously if this works, this should be offered to everyone, whatever other health conditions they have. We do know we're almost certainly going to end up with a lot more people who would like to take part, and we're super grateful for this, than we'll be able to include. And we need to decide how to select from within that. And it may even come down to something as crude. If there's people equally eligible, we might have to randomize it. I think we'll try and signpost anyone not able to take part into whatever other range of tinnitus studies are going on locally to them, locally to Oxford, etc. So this, we'd like to give an advance, a thanks to everyone who wants to be involved, and an apology already for anyone we might not be able to include at this stage.
Yep, I'm sure. Yeah, this is a question of the. I mean, people are also asking in the chat, like, how can I join the trial, etc. And I'm not sure if you mentioned just now if there are geographical limitations, but this is, of course, a key thing that you have an audience from all over the world. So, yeah.
No, and I think it's a good point. And I think we didn't want to put any geographical barriers up. And so everyone, please, if you want to, please register your interest, because you won't be able to take part if you don't, and hopefully you will if you do. We're not putting any geographical restrictions in. Essentially, you have to be able to come for all the sessions involved in that trial, and what's involved in that, and if that's manageable, is up to you as an individual. I think we'd be able to pay not huge sums of money for involvement, and we can cover a certain amount of travel, but because this is limited charitable funding, we'd probably have to put a limit on how much in the way of travel costs can be covered. So we wouldn't close it to people who would incur more travel expenses, but would only be able to provide so much to meet those.
No, that seems fair. I think if someone does come from abroad, I expect you would want them to stay near, like they shouldn't be traveling back and forth, but stay in the vicinity during the trial, or?
I think it'd be recommended. And I guess if you're going and doing air travel and disrupting your sleep, it may introduce other sources of variability in tinnitus symptoms that might interfere. But most of all, I think we're mostly just conscious. We don't want people to put themselves through something that will be disruptive or unpleasant or overly costly in their lives. We're still pursuing the short-term goals. So actually, if someone takes part in phase 1, this could be a fascinating thing to do. It could be wonderful if there's proof of principle, wow, we can quiet tinnitus. Because the next steps are further development and working out how to make it long-lasting, how to roll it out. It may still be, if we're super, okay, it's not totally impossible to get in this, tinnitus reduces and never quite gets the same severity, but it's more realistic. We suppress it for a period of time, the trial's over, it still goes back to how it was. So I don't want anyone feeling taking part in this trial is your only hope for this to benefit your tinnitus. Probably for anyone, whether you do or don't participate in the trial, if this works, the long-term hope is the long-term future that will be rolled out outside of a trial context. I'd say get involved if you like the idea of being at the forefront and helping to advance and be at that coalface of improving tinnitus science. That for me, that would be, because we know we'll succeed then. You'll be part of the journey. You'll have the interesting experience. We'll see whether it does something for your tinnitus. And if you're just in it looking for an interesting experience, I think you won't be disappointed. If you're looking for the cure for your tinnitus, that's a longer term thing.
Yeah, it's good to manage expectations on that, Will. And yeah, thank you for that comment. Yeah. So this question, I also saw it a couple of times in the chat, but just to make clear, you cannot register yet until, as Robin explained, the ethical approval has been granted at the University of Oxford, which will take typically a couple of months. So I guess you can keep an eye on our website and we can notify people when it's open for registration.
Hazel, and for both of our doctors, what does phase 1 look like? What is the length of time, or what would be involved in that level of participation?
So phase 1 for subjects involved is phase 1. This is what we're we would take, initially we need to take a baseline MRI, so that we can make sure we can target the locations we're after, and we design lenses, individual lenses for every subject, for every location. So we do that beforehand. And then there's the main part is a 4-week period where they will come in. We will target one of the 4 sites. There's 3 active sites and 1 control site, and that will be done randomly. So they will have the ultrasound, will have their tinnitus being assessed there. Then they will come back a week later, go away, come back a week later. So there would be it will be a 1 month essentially. There'll be an MRI scan that could be done a week or a few weeks or a month beforehand, but then there'll be a 1 month period where they need to be able to come into Oxford every week to be able to, for us to be able to do the ultrasound.
Okay, thank you.
All right. Do we need to protect our ears with earplugs when using TUS?
No, so you won't need to do that. That's the one nice thing about ultrasound, is because we are at frequencies well above what the human ear can hear. There are no direct auditory effects from the ultrasound, so it's nothing to be concerned there. As I mentioned earlier, what's interesting is, this is one of the things we found out when we did our first study, is that when the ultrasound passes through the skull, it does leave a tiny vibration left behind that passes through into the cochlea and gets, at least in the healthy volunteers I've used to date, gets picked up as a noise signal, and we will mask that. So you will be wearing earplugs for this, so that we can make sure you don't know whether the ultrasound is on or not. But there's nothing you need to do to protect your ears from the ultrasound. It's perfectly safe.
Yeah. I mean, Robin, this is really quiet sound, isn't it? Because I know a lot of people with tinnitus will have a degree of hyperacusis and have had horrible experiences due to moderately loud sounds and louder. It's just not even in that ballpark, is it?
No.
Right. Yeah.
So it would be more the MRI, as we discussed previously, that might inhibit some people from.
Exactly. Yeah.
Yeah.
No, I think the sound from being inside an MR coil is much more disturbing than anything that.
I recently did it's loud, and a double hearing protection they do give you. That they're pretty good about that these days. But yeah, it is loud. All right, from Joe, for Robin, some tinnitus patients report visual disturbances alongside their auditory symptoms, such as floaters, light sensitivity, etc. And I know you've done some work on visual perception as well. So, does your research frame tinnitus as auditory hyperactivity, and do these visual effects point to a shared underlying mechanism? Wow, this is really a fascinating question.
It's very nice that he's asking me, but I'm actually that's not my area of expertise. My area of expertise.
Yeah, that's what I figured.
I'm through the skull and focusing it in. So how the brain interacts and whether there is a joint effect between the tinnitus and the visual effects that are seen, I'm actually going to pass that ball on to Will, because I think he probably has a better understanding than I do.
Yeah, this reminds me that I have not yet made good on my ambition to directly study this. I mean, many of the symptoms that you mention, you would commonly see as part of the visual snow syndrome. So for anyone not familiar with this is less common than just all tinnitus, but the cardinal symptom is said to be static or snowstorm-like dots in your vision, a bit like a badly tuned analog TV. And then very commonly with it are floaters, visual after images, light sensitivity. And then the majority of people also experience migraine, and the majority experience tinnitus. But importantly, this is not, the symptoms are not due to a migraine attack or migraine aura. So for me, I think this is a very illuminating condition, and would strongly raises the possibility that there may be sensitivity traits that render some people, or at some stages or states or times in life, very susceptible to small sensory details in their sensory input that are not circumscribed to one system. But, as you allude to, if you're more sensitive to subtle sounds, which might be associated with hearing tinnitus, whereas someone else's brain wouldn't pick up on it, are you also more sensitive to things in your vision, touch? My hunch is surely lots of people this has got to be a big part of it, along with how much you have going on in that particular system, like degree of hearing loss. We're doing quite separately to this a bit of research, just looking at symptoms in large groups of people to examine how much your sensitivity to various things in one domain, like vision, relates to another domain, like auditory and touch. And then does that relate to whether you have a particular condition like tinnitus, visual snow syndrome? So there's huge overlap. I mean, I could go on about visual snow all day. It's fascinating.
It's a fascinating condition. I agree. And when I learned that, I think it's 60% of people with visual snow also have tinnitus. I mean, that cannot be chance. There must be something going on there. And I don't think it's been really investigated by anyone.
It's not had the research attention it should. And I don't think the links are restricted to just this. I think that probably the visual snow syndrome is the tip of the iceberg, but similar links and underlying mechanisms in slightly less obvious forms maybe at play in a much higher proportion of cases as well.
Yeah, yeah. Yeah, there's also an organization called the Visual Snow Initiative, which I've been in touch with at some points in the past. Maybe could be interesting to reconnect with them. Let's see if we have one more question from Francis. I'm aware Dr. Sedley released some success with sound therapy alone quarantine tinnitus. What are the updates, and could this be used in conjunction with TUS?
Yeah, thanks for the question. So, quite sort of inadvertently, there did end up being a lot of media interest about this. So this was work we actually did a couple of years ago for a new type of sound therapy, sound-only therapy that we think maybe helps break up patterns of activity between neurons in the auditory pathway that respond to different frequencies. So rather than all the frequencies firing at the same time, you keep changing the timing and it weakens the links. We've had success in one initial trial. It was very modest. The average quietening of tinnitus against the sham form was only about relatively 9% quieter. So hugely exciting that we think it seems to work and do something. Needs a lot more development. Updates on this, we're seeking funding still. There's options we're exploring to try and just automate this so that it can be delivered and tested and improved on a big scale and open, getting involved in the trials to more people. So I'm sure you'll hear about it in due course if and when we get some. We are, speaking of combining that with other things, we are already running a trial where this is being combined with transcranial direct current stimulation. That's specifically for acute tinnitus, because actually we know that the sounds I've just told you and TDCS, although they're significantly effective, it's quite modest. So we're doing it in acute tinnitus to see that's where we think we have the best chance of making the biggest difference out of relatively weak techniques. But as I mentioned that more just as in we do have an interest in combining treatments as a way of making them more effective. If we can make these sounds better or show they do something, and ultrasound does something that isn't a full cure, I think inevitably one is going to want to try and combine things that have some effect and work out a treatment protocol that includes everything that can give you value. So I think there could easily be the ability to combine ultrasound with this type of sound therapy, other types of sound therapies, other types of brain stimulation, all sorts of things.
Yeah, I do think combination therapies are anyway ultimately going to be how we can help the greatest number of people with tinnitus. All right, Gail, one of the best webinars I've ever attended. Thank you, Gail. In spite of our tech issues, that's great to hear. Many thanks to you for addressing this condition. I wish you all the best in your research, and we'll follow it with interest. Yeah, that's not a question, but a very nice comment. Thank you. I think that also means we're sort of at the end of our questions, although we didn't cover all of them, but we always have to kind of make a selection for what's most within the scope for the particular day. I see another nice thank you so much for your work. It gives us a lot of hope from Renee. Yeah, there you go. Thanks for pulling it up. Great. Well, then I will ask our three speakers if they have any final remarks or sort of anything that we didn't cover that you wanted to bring up, maybe starting with Robin.
Sure. So again, I'd like to just thank Tinnitus Quest and all of you who support Tinnitus Quest, because for us to be able to do this work, having your support is just critical and for us being able to advance this going forward. So So thank you to Hazel and Marku for all the work that they've done with Will and I over the last couple of months in really being able to help frame the best way that Will and I can approach this, but also to everybody who has contributed to Tinnitus Quest to be able, so that we can carry on with this research. It really is so important for us to be able to advance this new technology. Will, was there anything you want to add?
Completely echo that. And, massive thanks to literally everybody present here and everyone else who's been involved too. Whatever, every bit of research that's invested in, everyone who's donated into that, there's always an element of risk and chance. If we knew it would work, there'd be no point doing it. But what we do know is if enough people keep placing enough importance, keep donating money, keep donating their time with volunteering, that is what will eventually get us to where we need to be. So, I appreciate any thanks directed our way for now. I'll accept it as thanks for attempting to help. And I think we deserve an equal amount of thanks to everyone else here who cares every bit as much as we do. And I hope that this leads to somewhere where we can actually deserve any more thanks for genuinely moving the field forward. And I think time will see whether any of those are, proved to be founded and whether the science lives up to expectation. We'll do our best.
Yeah, thank you, Will. Bill, thank you for co-hosting with me. Is there anything you want to share in final remarks or thoughts?
No, I started with gratitude. I want to end with gratitude. Thank you to Dr. Cleveland and Dr. Sedley. Hazel and Marku, thank you for inviting me to join. And to all of my fellow tinnitus journeyers, just want to remind you that we are a very powerful community when we stay connected and we continue to support the work of Tinnitus Quest. So tell your story, and hopefully we will all as a community play our part in helping advance the research and the field.
Wow, Bill, yeah, I couldn't have phrased it any better. Thank you so much. Thank you to the audience for joining today and for sharing all those very thoughtful questions. We really appreciate it. We hope to see you at future events. Again, please go to our website to donate if you can and feel so inclined. And like Bill said, we're stronger as a community, and none of this would have come about without the community support. So thank you all so much, and we will now end this event and hope to see you all again soon. Bye.
Bye, everyone.
Bye.